We'll get started. It's going 6 o'clock. My name is Chris and this is Kieran. Today I'll talk to you about trauma and orthopedics and a bit of rheumatology, and then Kieran's going to talk about some respiratory conditions. So we'll just go through a little bit about what we'll do. I'll talk to you about trauma and orthopedics. I'm going to keep it very simple because that is all you're going to need for the exams. What they're going to ask you about is very simple and straightforward, nothing complicated. So we'll go through everything that's in your list of conditions you have to know. We'll talk a little bit about how you should think about it in terms of the OSCE. Go through a couple of cases with you, and we'll go from there. So your ACT conditions are what you have to know about things you need to do are septic arthritis and temporal arteritis. And then the main conditions in orthopedics and rheumatology are obviously OA and RA, gout, ankylosing spondylitis, polymyalgia rheumatica, reactive arthritis, osteoporosis. And then you've also got a list of trauma conditions that you're supposed to know a little bit about the treatment of. So we'll go through those as well. Just wait for these to take a seat. Okay, so we'll start off. I'm going to ask you some questions as we go along. I don't know how you want to do it. If people want to put their hand up and volunteer, or if we should go along and quiz each person in turn, how would you like to do it? Shout out. Okay, so give me some differential diagnoses of this if you get this picture in the slideshow. Yeah, and that's obviously going to be your first one, but what else have you got to consider in a picture like this? Yeah, exactly. And what's the thing? Obviously, septic arthritis was the one that everyone was shouting to start with. What makes you think that above the others in this case?
There's a graze on it.
Exactly. There's a graze on the shin. That's obviously a point that infection could get into. Okay. So in each condition, I'm just going to go through it like this. Obviously, signs and symptoms, then investigations you would do, and then treatment. This is all you'll need to learn for the exam for each condition. Don't go into lots of detail when you're revising. There's no need. Have the basic background of every condition, and then learn a little bit extra as you think is necessary. But really, it's all about the core knowledge for each condition. So in septic arthritis, you obviously get the red, hot, swollen joint that you saw in the picture. They'll complain of a decreased range of movement. They can't weight bear on it, and then obviously as it progresses, they'll start to get the systemic symptoms. And the key point with this is it can destroy a joint within 24 hours. So it's very important that as soon as you suspect it, even if it's just on your differential, it's not the top one, it's important that you exclude it. So obviously you need to exclude systemic sepsis with their bloods, and obviously you need to get a joint aspirate and send it off for cultures and sensitivities. The treatment, if you do suspect it, is IV flucloxacin, benzopenicillin, prior to getting any cultural sensitivities back, and then you'll often take them to theatre for drainage and irrigation of the joint to wash out any infection prior to it managing to destroy the joint. So, we'll go to a presentation now. So, if someone comes into you with a headache, shout out some differentials of a headache. Migraine, yep. Tension. Subarachnoid, yep. Yep.
Meningitis.
Yep. And if I was to say it was behind one eye, does that make you think of anything?
Temporal arteritis.
Yep, and cluster headaches as well. So you've got all the main ones there that you need to consider. So if the presentation continues, and someone says that a scalp hurts when they brush their hair, what does it instantly make you think of? Exactly. And it really is this simple. In the exams, especially in the written, they will give you a barn door sentence like that. As soon as anyone says, my scalp hurts when I brush my hair, or anything like that, my jaw hurts when I start to chew, which is the next part of this presentation, if you haven't got it, then you know exactly what it is. And they really don't try and trick you. So just know these basic steps of every presentation, and you'll be absolutely fine. So a little bit about temporal arteritis. So the signs and symptoms are as above, what we've gone through. And the key thing here is that it progresses to visual disturbances, which cannot be resolved. Once you have loss of vision from this condition, very rarely are you going to get your sight back, and that's why it's one of your conditions that you have to be able to pick up and treat and deal with straight away. Obviously, the investigations here, you will see systemic signs of inflammation, but you need to do a temporal artery biopsy in order to confirm it. So if we do a temporal artery biopsy on someone who you suspect as having temporal arteritis and come back as negative, what are you thinking? Exactly, that's it. That's the key thing. Don't exclude it just from one negative biopsy. You need to do more than one, and even if you have multiple that come back as negative, it's very important that you still consider it and possibly treat it. So the treatment is steroids, because it's an inflammatory condition, and you have steroids over a longer period of time. So you start off with 30, decrease it by 5 milligrams every month. And as I said again, The signs and symptoms, the investigations and the treatment are as simple as I put them out here. Don't go learning huge lists of every investigation and treatment that you could possibly do, because it's really not necessary. Okay, don't shout out the condition, tell me the signs that you've got here. So the top left, this one here. Yep, this one. Yeah, Cutaneous. And down here, what's this finger? Yeah, that's the one there. And what do they all represent? Yeah. So rheumatoid arthritis. Your presentation, either in the clinical sort of text in the written, or if you get this in the OSCE, it's going to be a female between 30 and 50, where this is the classical presentation. The key point that you have to talk about to differentiate it from other joint conditions is the early morning stiffness, and this lasts for over an hour. It's progressive, so it's getting worse, and the key point is that it's also symmetrical. There are key joints that it affects as well. The most common one they love to ask you about is the base of the thumb. Okay, so in terms of investigations for this, there are obviously lots of different specific tests you can do, but the key ones that they do in rheumatology clinic are rheumatoid factor and then CCP. These are just markers within the blood that they will test that tell you whether someone has rheumatoid arthritis or not. And then the other thing they love in exams is the X-ray. So differentiating OA from RA on an X-ray. The way to remember it is SPADES for rheumatoid arthritis. You get soft tissue swelling, periarticular erosions, absent osteophytes, deformities, erosions, and subluxation. Just one of those acronyms that you just rote learn. The treatment is progressive, so you start off with some things like exercise, progress to NSAIDs as required, DMARD, so methotrexate. For acute exacerbations, you can use steroids, and then if someone's really suffering later on down the line, you start to look at things like biologics. But for the OSCE, we just talk about simple things such as exercise programs, keeping them moving, and then simple treatments like NSAIDs prior to you would say that you've then referred. Okay, so what have we got here? What's on this X-ray? So I've told you about SPADES for rheumatoid arthritis. What have you got on this one? And what makes you say that it's osteoarthritis? Yeah, so it's just on one compartment, just on the medial compartment, and it's not bilateral. Okay, so it's not symmetrical. Who knows the acronym for osteoarthritis? Yeah, LOS. Okay. So loss is the loss of the joint space. If we go back, you can obviously see that just here, you completely lost the joint space. You have osteophytes. I don't know if I can convince anyone that there are some osteophytes in there. Maybe this little guy here, I'm not too sure. Subchondral sclerosis and subchondral cysts. You won't ever be asked to point these out on an X-ray. Know that they're some things you should look for to be able to say them in the OSCE, but you'll never be forced, if someone shows you an X-ray, to point out a cyst unless it is incredibly obvious. Treatment for osteoarthritis, weight loss and exercise. Again, this is really key in osteoarthritis. And this is what you really have to hammer home to the patients, especially in the OSCE. That the more they can lose weight, the more they can exercise, the better the situation will be for them. Simple analgesics, paracetamol, NSAIDs, and then arthroscopic washout, which has been shown to be effective. No one really knows why, because it doesn't do much other than change some of the synovial fluid within the joint, and then later on arthroplasty as required. Right. I'm afraid at the moment we're just going to go through a couple more conditions and just give you the information on them so you've got it when you're at home. Gout. So it's increased serum uric acid levels. This leads to monosodium urate crystals within the joint. The key point here is differentiating between gout and pseudogout, which I'll show you next. The key thing for gout is that what they love in the written exam is they'll say you've taken an aspirate of it, looked at under the microscope, and there's birefringent negative needle-shaped crystals. And that's different to pseudogout when you get birefringent positive rhomboid shaped. We'll come on to that next. The symptoms are the same as you got in the differential diagnosis at the start. So you get a red, hot, swollen joint. You have the classical portly old gentleman who loves his port and red wine and red meat and that type of thing. They really won't try and trick you. It'll be that simple, and he'll get it. Treatment-wise, acutely, you give them NSAIDs or colchicine. They're more towards NSAIDs these days. And then allopurinol later on. The important thing is not to give allopurinol straight off in the acute phase because it makes the situation worse. Pseudogout. So this again is an inflammatory arthropathy, this time caused by calcium pyrophosphate crystals. Symptoms are exactly the same apart from you get it in different joints. This time you might get it in your knees, so the most common, and the other larger joints. What you may be shown in the picture in the slideshow is this, which is called chondrocalcinosis. As you can see here, this slight line that you can see along the synovial membrane where calcium has been deposited, that's typical of pseudogout. And obviously you have the birefringent positive rhomboid crystals. Treatment again is with NSAIDs and analgesics, but you don't go on to give them allopurinol. So obviously you treat them the same in the initial phase, you get the joint aspiration, get it under the microscope in the labs, and then you have your diagnosis, and then that decides whether you give them allopurinol at a later date or not. Okay, I apologise again for just the list of treatment and investigations and things, but these are the key facts that you'll need for the exam, so we'll get them down for you. Okay, so another presentation. So someone comes in, they've got right knee pain. What are your differentials?
Osteoarthritis.
Yeah, osteoarthritis, rheumatoid arthritis, septic arthritis, yeah.
Trauma.
Yeah, trauma. Yeah, other one we just mentioned, pseudogout. Exactly. Can anyone come up with some more obscure ones? Reactive arthritis, yeah. Anything else?
So like
So that again, writers, yeah, possibly. We'll come on to that. Yeah. Okay, so it's happened over 2 days. It's red, it's swollen, it's hot. You're probably deviating towards septic arthritis, gout type picture. Then if they go on to tell you that they had diarrhea and vomiting 2 weeks ago after they had a takeaway.
Reactive.
Exactly. That's all you need to know. That'll be the classical presentation that they'll give you. You won't see this in the OSCE because it's too complicated and too obscure, but you might get this history in the written clinical synopsis. So, reactive arthritis is a sterile arthritis typically affecting the lower limb, 1 to 4 weeks following urethritis or dysentery. Investigations as follows. Treatment is just to rest it, give NSAIDs and simple analgesia versus the pain, and it will get better. And obviously you mentioned writer's syndrome. Again, it's not something you need to learn a lot about, just know about it. The rhyme, I can't see, I can't pee, and I've got a pain in my knee. Anyone know what this is representing? Yeah, and what's the posture called? Yeah. So it's a chronic inflammatory disease of the spine and SI joints. Lower back pain worse at night, early morning stiffening relieved by exercise, progressive loss of movement or directions, and the question mark posture. It's a clinical diagnosis, that's the key point. So you don't really do any investigations, you won't see anything on the bloods. If you do an x-ray, you'll see a bamboo spine, but you don't actually need to do one. And the key point here is the intense exercise regimen from the very beginning. The sooner you can get these people exercising, the sooner you can get them better, the better it will be for them. Polymyalgia rheumatica. It's another simple rheumatoid problem. You see it quite commonly. They may put it in the OSCE, and they may not. You may just get it in the written exam. It's gradual onset, symmetrical again. It's shoulders and proximal limb muscles. People get a lot of pain when they shrug, pain in their shoulders when they first wake up. The blood test, you've got raised CRP and ESR because it's an inflammatory condition, and you treat it with steroids. So osteoporosis. It's a quantitative reduction in bone mass. Okay, that's different to a qualitative, which is important. They'll talk about that another time. So females, smokers, low BMI, steroids. So you won't really know about this until they come in with some other problem. You won't regularly look for it. So when someone comes in with an insufficiency fracture, then that's what you have to think about osteoporosis, especially if they're doing long-term steroids. So you do a DEXA bone scan, and that'll tell you, and then you treat them with bisphosphonates. It really is this simple. Just learn little bits of information for each condition. That's all you need to do. So how do you need to think about it in the OSCE? So you have someone come in and they have joint disease. So then these are your options. So it's either going to be osteo, rheumatoid, crystal arthropathies or septic arthritis, which have a similar presentation, or it'll be one of the more complicated seronegative things. Okay, so let's go through a presentation. So someone comes in and they've got a pain in their thumb. Tell me some questions that you're going to ask them to try and differentiate between these things. When did it start? Yeah.
Well, Socrates.
Yeah, exactly. So Socrates, the pain. So you're going to find out if it's symmetrical, whether it's worse in the mornings, the early morning stiffness, if it's red, if it's hot, if it's swollen. So in every clinical scenario you get in the OSCE, have all of these differentials, do the simple Socrates, and then ask a specific question for each diagnosis. That's what they want. They want you to be shown to be ruling out certain things. So if someone comes in, they've got a barn door osteoarthritis, but they'll still want you, and you've still got a mark for saying, is it worse in the morning in the first hour, or is it hot, is it swollen, that type of thing. Make sure you get the important negatives as well as the important positives. So last but not least, trauma side. Ankle injuries. They love ankle injury leads for some reason, I'm not too sure why. So you want the history, mechanism, inversion, eversion. You need to learn the ocular ankle rules, which obviously here, I'm not going to go through them because they are what they are, you just have to rote learn them. And then that's it. That's all you need to know for an ankle injury. And then obviously the simple, take the history, do the examination, and go through the osteoarthritis rules. Long bone fractures, you have to know how to describe them and not much more than that. So hairline versus simple versus comminuted versus compound if it comes out of the skin. If it's linear, if it's transverse, if it's oblique, or if it's a spiral. So you can tell me what this picture just here is. How would you describe it? Simple and... Yeah. This one? Middle one? Comminuted, spiral, yep. And finally over here? Exactly. So that's another probably a compound comminuted spiral fracture. Risk factors, all you need to know is the difference between Colles and Smiths. So they're both distal radius fractures. In Colles, the distal segment is posterior, so it's sat behind. And in Smiths, the distal segment is volar, so it's sat the palmar side. That's all you need to know. Neck of femurs, so they're going to have pain, unable to weight bear, shortened and externally rotated. That's the key thing that you'll get in the presentation, especially in the written synopsis. You need to know if it's intra or if it's extracapsular, because of the blood supply goes through the femoral neck. Therefore, if it's one side of the femoral neck, then the head is at risk of AVN. Okay? You need to know the Garden classification. If it's 1 and 2, you use a screw. If it's 3 and 4, it's Ostermoor. So the way to think about it here is if it's one side of the neck, then obviously you're at risk of AVN, so you have to get rid of the head, and that's when you give them the hemi. If it's the other side, then the head's not at risk because it's still going to get its own blood supply, so then you can use a DHS screw to fix it. So here in this one, obviously the fracture is here. You take the intertrochanteric line, so lesser and greater trochanters, draw a line. You can see here that the fracture is obviously proximal to the intertrochanteric line. So then obviously this head is at risk of necrosis, so you have to take it out. In this case, you'd use a hemi. In the next one, it's distal to the intertrochanteric line, which is roughly here, even though the lesser trochanter has been broken off. The head's no longer at risk of AVN, so you can just put a screw through that and fix it in place. Major trauma. Right, last but not least, major trauma, how are you going to deal with it? How have you been taught to deal with any emergency situation? Exactly. So, go through. A, tell me what you're going to do. Yeah. Yeah. B. Yeah. Check air entries, bilateral, etc. You've got all that. It really is that simple. As soon as you come up with any major trauma situation, that's all you're going to have to do. They're not going to expect any more. They're not going to expect you to be able to manage them. They just want you to be able to get there, deal with the important things first off, ABCDE, and then move on. And someone else will be there to support you. And it's that simple. Any questions? No? All right, thanks.
Alright, so next we're going to talk about asthma, COPD and anaphylaxis. Now, the first thing we need to say about these three topics is that they are all extraordinarily guideline driven for what you need to know for your exams. So, for the asthma and COPD, if you learn the BTS guidelines, you will already be sort of 85 to 90% of the way there to what you need to know for your final exams. From the anaphylaxis point of view, there's a great section in the back of the cheese and onions that will tell you the majority of what you need to know for an OSCE on how to manage anaphylaxis. Okay. The other thing just to say is that I'm not from Leeds, I didn't train in Leeds, so although I'll do my best to try and cover things from an exam point of view, I'm probably not the best person to ask, but I've found out a few of the things that have come up previously. So because things are quite guideline driven, although I've put in the slideshow the actual guidelines themselves, I thought I'd try and throw in a few sort of example questions and try and keep things as clinically relevant as we can, because otherwise this is going to get very dry very quickly. So I'm just going to start off by saying a few things about respiratory OSCEs in general. Then we're going to talk about acute asthma management, acute COPD management. We're not really going to talk much about the chronic COPD management because, again, it's quite a good sort of like step-by-step guide, and the same is true for the chronic asthma side of things, and then quickly just run through anaphylaxis. So the first thing to say is just if you think of, in general, what's going to come up in OSCEs in terms of a patient you need to examine, not a scenario that you're given or not explaining something. The conditions that people have to be common because they need to be able to replicate this across the number of days, and they usually have to have more than one patient. They have to be chronic, and they have to have good physical signs. So this actually means that for almost all of the general systems examinations, it's fairly predictable what types of things are going to come up. And so you can actually prepare almost word for word what you're going to plan in terms of what you're going to look for and what you're going to present for each of these conditions. So from a respiratory exam point of view, what are the conditions that are likely to come up in an OSCE? So you're going to have to speak up. Bronchiectasis. So bronchiectasis is a great one. Okay? And bronchiectasis often goes hand in hand with another condition. Cystic fibrosis, yeah. Okay? What else is possibly going to come up? So so fibrosis is another one. Yeah, so we've got fibrosis, bronchiectasis, CF. Anything else? COPD. You could get COPD, but you tend not to necessarily find that much by way of physical signs. So they can wheel them out, but they tend not to bring them up because they don't have so much physical signs a lot of the time, unless they've got an acute exacerbation. They might have somebody who's got really bad COPD who has a wheeze, but often that's not what they rule out. So things are COPD, as I said, they sometimes do bronchiectasis and CF, and the other one is pneumonectomy or lobectomy, because these are obviously patients who they've had a chunk of their lung or the whole lung out, and they don't change. They tend not to be particularly sick now that they've had their operation and they've recovered from it, and it's a good thing for them to test because people will miss the signs, particularly looking at the back. Okay, so in terms of chronic asthma, the BTS has a step-by-step guide of exactly how you should manage chronic asthma or asthma on a sort of chronic basis. And unless anyone's particularly dying for me to run through it, I think we can gloss over this. It's in the slideshow, it's in the handouts, and you basically just need to commit this to memory. There's not much more to it than that. What gets slightly more interesting is when you start talking about acute asthma and what happens when you have somebody who comes in who has a background of asthma who is acutely unwell. So I would like you guys to imagine that you are in A&E, you are the F1 who's working at St James's, and you are asked to see a patient who is a 27-year-old who has a known background of asthma, who has come in acutely short of breath. How are you going to investigate and manage this patient? Okay, yeah, so ABCDE. So as with any investigation and management, you will not be wrong if you say that you're going to take an ABC approach. Okay, so what investigations are going to be important for you to do in a patient who's, you know, akin to this that I've just described? Right, so you want basic odds, so you want SATs, peak flow, respiratory rate, yeah. Yeah, so you want to do an ABG. Okay, why are you doing a chest X-ray? Okay, so someone's mentioned one of the things you want to rule out is you want to rule out whether or not there's an infected element to it. So yeah, do they have a pneumonia? Anything else that you're looking to find or rule out? On pneumothorax. Yeah, so pneumothorax. So people who have asthma are more at risk of getting a pneumothorax. But also, you know, you could treat someone for acute asthma and really their problem is that they've got a pneumothorax. Okay, so is there anything in particular that you want to know when you're talking about your clinical examination that's going to inform you as to how severe this asthma attack is? So yeah, so do they have a silent chest? That would be a particularly worrying sign.
If they could talk in sentences.
Yeah, so how much of a sentence can they manage to get out before they run out of puff? Anything else?
Raised CO2.
Yeah, so someone just mentioned raised CO2. So this is when you've done your blood gas, you're looking at how well they manage to oxygenate, but also looking at how well they're managing to get rid of their carbon dioxide. dioxide. And what things would be worrying on your blood gas? Yeah, normal or raised CO2. So when you look at patients who have asthma, you need to have an idea of how severe it is. And again, there's a classification for how severe it is. So it's either moderate, which is basically somebody who's got a reduced peak expiratory flow, so between 50 and 75% of their best or predicted, none of the features of acute severe asthma, and increasing breathlessness. And then you move into the acute severe category, which is anyone who has basically less than 50% peak flow, a respiratory rate greater than 25, they become tachycardic, and as somebody mentioned, they're completing full sentences. Then on top of that, you can go into the life-threatening. So this is somebody who's already fulfilled the criteria to be in the severe asthma, but then you've taken it a step further, and you have to think, right, this person is really at risk. Okay? So this is somebody who's got a peak flow less than a third of their predicted. They've got a low oxygen. That's either on finger probe at 92% or either on ABG, which is less than 8. And as you said, a normal or raised CO2. Okay? And then somebody else mentioned the silent chest. Cyanosis is something you want to look out for when you're examining them. If someone is cyanosed and you're thinking acute asthma, you need to start getting very worried, because that's obviously, they're beginning to get to the point where they're not really perfusing peripherally, and so you've got to start worrying about whether or not they're going to have problems perfusing, delivering oxygen, I should say, peripherally, and whether or not they're going to have issues delivering oxygen centrally. Then there's the poor respiratory effort, any arrhythmias, and exhaustion. Now, if you were managing someone with acute asthma, obviously there's also a near fatal, which is the raised PCO2. Okay, so if you were managing this person now, so moving away from the investigation side of things, what are you going to do for this chap? So we've now, let's say, we've seen that he's got a normal chest X-ray, he's got low oxygen on his blood gas, his CO2 is normal, and he's unable to complete full sentences. Okay, so sit him up, and I heard somebody else say oxygen. How are you going to give him the oxygen? Yeah, so 15 litres via non-rebreathe. What else are you going to do? Okay. Now, how much salbutamol are you going to give? 5 milligrams. Okay. So ipratropium, yeah. And how much of that do you give?
500.
Yeah, so 500 micrograms, so 0.5 milligrams. This is one of the kind of scenarios where you would be expected to know drug doses. In fact, acute asthma, acute COPD, and anaphylaxis are all examples of where drug doses would be expected of you. Okay, so you've given your salbutamol, you've given your ipratropium. What are you going to do now? The patient's not really improved a whole lot. Still, only saturating at 89%. Okay, so somebody's mentioned theophylline. Now, theophylline is a bit of a contentious point as to whether or not it should be used or not. It used to form part of the guidelines, but I think since 2004 it has been kind of removed. That's the kind of thing you would initiate with specialist involvement, so you need a consultant to start something like that. But for the time being, you wouldn't do that as sort of an F1 trying to manage the patient. So steroids. So what are you going to do in terms of steroids? Okay. So someone mentioned oral. Yeah. So you give them an oral dose, and if they were going to fail to improve further, so you give IV, and you would also IV steroids. So you give hydrocortisone, and you would also go on to give magnesium. Now, it's worth mentioning that you can give your nebulizers back to back, so you could give 3 cycles of salbutamol, and you could, at that point, write up 3 at the point at which you're prescribing it in the first place. Okay? So as we've said, you give high flow oxygen, you give your 5 milligrams of salbutamol, your 0.5 ipratropium, you give your oral steroid, and then hydrocortisone, and you give your magnesium sulfate. Has anybody got any questions?
Do you give oral steroids as well as IV hydrocortisone?
Yeah, you can give both. And the important thing is also the oral steroids you would normally give, but they're probably not going to make much of a difference in the acute setting, and you would continue those for a few days because this patient's going to need steroids for a good few days. Now, talking of steroids, if you had a patient who's come in under you and you have given them steroids, What do you have to bear in mind in terms of how long they've been on steroids? Okay, so if someone was on it really long term, you'd worry about bone protection, but an asthmatic, probably who's on it for an acute exacerbation, isn't going to need bone protection. There's something else that would worry you. So somebody's mentioned essentially Addison's disease, so where you've suppressed their ability to secrete steroids, and so if you give somebody steroids for more than 7 days, you need to consider weaning them off those steroids. You can't just stop them abruptly. So 7 days really is your cut-off. Okay? So I've also included in the handout just a list of some of the things that you would want to bear in mind in terms of when you would refer to an anaesthetist. And the reason I put this in is often if you're presented with an OSCE situation and you're given an ABC scenario and you talk your way through it, at the end, one of the things that they will ask you is often where you would want to send this patient. So knowing these things will give you an idea of whether or not you're going to send this patient to HDU or whether or not you're going to send them to ICU, which may seem slightly fringe in terms of finals, but it might actually be quite useful to know if you end up working with these patients in the future. Okay. So I've got a couple of questions, and I would like to credit someone because I did not write these questions. These are questions that I had from some of my old revision slides. So I'd like to thank Beth Walker for her very good questions. So a 30-year-old woman arrives in A&E having a severe asthma attack. She's also 29 weeks pregnant. What is the appropriate management? Okay. So these are your options. Are you going to give 100% oxygen via a non-rebreathe mask, salbutamol nebs, ipratropium nebs, and hydrocortisone? Are you going to give just the oxygen and salbutamol, the oxygen, the salbutamol, and the ipratropium, the oxygen and the ipratropium, or the oxygen, the salbutamol, the steroids, the magnesium, and intubate? Okay, let's have a show of hands. Who wants to go for A? Who wants to go for B? Who wants to go for C? Who wants to go for D? And who wants to go for E? So half of you are going to make no intervention. Okay? The answer is A, and that's because the fact that she's pregnant makes absolutely no difference in this case. You treat it as you would any other asthma attack. You give them the salbutamol, the ipratropium, you give them the steroid, and you give them the oxygen. Okay? So the next question is kind of really to highlight that although we're talking about asthma in terms of just acute asthma, asthma obviously filters into other areas, and particularly what medications you're allowed to give or not allowed to give. Okay? So if you had a 28-year-old woman who was admitted with palpitations, she's got a blood pressure of 110 over 80, she's got a heart rate of 160, and she's got a drug history of fluoxetine, salbutamol inhaler, and tranexamic acid, and that is the ECG that you have. Okay? So from that rhythm strip, what is the... So SVT, yeah, so it's SVT. Okay? So how are you going to treat this lady? Okay? So let's have a show of hands. A. Okay? B. C. Okay? D. And E. Okay? There are a couple of hesitant hands for, in fact, the right answer. And the reason is because this lady has a salbutamol inhaler, you've got to be worried that she has asthma, and you can't give adenosine, which would be the first line in asthma. So you would give verapamil as a second line, which is a bit of a sneaky question, but it's just there to highlight that certain drug groups you're not supposed to give in asthma. So non-steroidals would be an example of that. And just to make sure that when you're looking through your sort of pharmacology, to have a look at what the contraindications are to a lot of the common first-line drugs for medical emergencies, because they do, in written papers, sneak in these sorts of questions, which would be a shame to miss, given that it's just a couple of extra little things to look at when you're looking through the back of your cheese and onion. Okay, so in terms of chronic COPD, I'm not going to say much in terms of the pharmacological therapy, but it's worth mentioning that one of the most important things that you can do in COPD is get the patient to stop smoking. And it's amazing how often people forget this. And I remember being told how often people forget to mention this when they're quizzed on it in OSCEs. So try and remember that, because that's going to hopefully stop them from progressing any further. And then the other things that sometimes they ask questions about are long-term oxygen therapy at home. So it's worth having a bit of knowledge about that. And then one of the other things that you can treat people with is home NIV. I would say this is not the realms of finals. Do not bother touching this with a 10-foot barge pole. This is a law of diminishing returns. Do not. You will waste a massive amount of time and get very little reward for learning anything about it. Okay? Acute COPD. Okay, you are called to A&E again, and you're asked to see a lady called Deirdre. And Deirdre is an 89-year-old lady who has smoked 100 cigarettes a day for her entire life and has a background of COPD. She's been found on the floor in a heap by her son, and they've called an ambulance. Okay, and she's now arrived in A&E. She's breathless, and she doesn't look very well, and the ambulance crew are looking very agitated that this lady's very sick, and they're quite keen for you to take a look at her and see what's going on. Okay? How are you gonna, again, how are you gonna deal with this patient? So yeah, ABC, okay. So what's important to find out about this lady in particular? Okay, so yeah, so what her sats are like? Okay, so she's saturating at 97%. Okay, she's doing ABG, and you see that she's got type 2 respiratory failure, and she's acidotic. Okay, so somebody has hit the money, straight on the money there, and said, are they a CO2 retainer? Yes, she has an elevated bicarb. Okay, what did you want to check now? Yeah, so she's been whacked on 15 litres of oxygen, okay, and she's now acidotic as a result of this. So what is your first thing that you're going to do?
Take it off.
So someone said take it off. You could take it off. Take it off and replace it, yes. So I wouldn't just take it off. I would take it off and replace it. So what sorts of oxygen level do you get this lady? Okay, so I can hear lots of things being shouted. Venturi, yeah, but what sort of rate? What flow rate? 24, yeah. So you could give about 2 litres, 2 to 4 litres of oxygen. Okay, so if you've done this and you've now turned down her oxygen, what do you want to check, and when do you want to check it? So you want to check her SAT. So her SAT's come down to now she's saturating at 90. Okay, so we'll do an ABG, and what sort of time frame do you want to do the ABG? Yeah, so 20 minutes to half an hour. Okay, so if after 20 minutes to half an hour her ABG has not improved, does anybody know what you would do? So it's not CPAP that you would use, BiPAP. CPAP is what is used for sleep apnea, BiPAP is what's used if you've got someone with COPD retaining CO2. Okay, so you turn down the oxygen. What else might you do for this lady in terms of managing her? So nebs, yeah, okay. So what are you going to give? Yeah, so it's the same as you would give for the asthma. Okay. Is there anything else you're going to give? Steroids, yeah. So it's really important to give steroids in the COPD patients. That's going to really be the thing that makes the big difference. These patients are going to probably feel a bit better from their salbutamol, but it's not going to deal with the underlying issue unless you give them the steroids. Okay, so you give them the steroids. Anything else you want to consider doing? Any investigations? So chest X-ray. So why are you doing a chest X-ray? Yeah. So what you want to try and discern is this an infective exacerbation or a non-infective exacerbation? Because what difference is that going to make for you? So yeah. So whether or not you're going to give antibiotics. Okay. So you want to. So in terms of the basic things for the acute exacerbation of COPD, you want to give them low flow oxygen, you want to give them the salbutamol, the ipratropium, the steroids, and then if they're not improving, you need to consider sending them to a respiratory HDU or a normal HDU and putting them on non-invasive ventilation. and then you need to consider whether or not you're going to give antibiotics. Okay? So just to talk for a second about chronic COPD. So we've already covered that in the previous slide. So with the COPD, in terms of what's going to come up in your exams, COPD questions are extremely easy to ask from many a standpoint. It comes into, as we've already touched on, CO2 retainers, too high in oxygen. It comes into asking questions on ABGs, and if you can get practice looking at ABGs, I would recommend doing it, because what they'll often do is, if you're asked in your clinical skills station to do an ABG on a dummy, they'll often present you with an ABG result afterwards, which you'll be then asked to either interpret to a clinician or explain to a patient. And practicing explaining an ABG to a patient is definitely something I would recommend doing, because it sounds like it'd be really easy, but putting it in really simple terms is actually quite tricky. So then, last but not least, is anaphylaxis, which is a sort of fairly it's a common thing that you'll see, and it's something that you really need to know how to manage. So what would you do if you were faced with someone who you thought was having an anaphylactic reaction? So so you do your ABC, but what stepwise things are you going to do? So other than putting the ABC to the side for a second, what are your
call the peri-arrest team?
Okay, so you could do, and in fact somebody's just said you would call the peri-arrest team. So you wouldn't be wrong to dial for some help and call 2222, and you might end up, by the time that they arrive, that you've managed to salvage the situation enough that they're not particularly unwell, and you might have an angry anaesthetist on your hands. But you wouldn't be wrong to do it, and if they ended up deteriorating, it'd be extremely helpful. So so you could call the peri-arrest team, but I'd say before you do that, what are the things you're going to do? So remove the cause. I think that's a good idea. So if someone's got an antibiotic running through a drip, or anything along those lines, if you stop it, that will obviously, to a certain extent, stop it from getting even worse than it already is. What else are you going to do? Okay, so you're going to give oxygen. Okay, so yes, you want to consider airway adjuncts if necessary. Okay, adrenaline. Okay, how much adrenaline? So, of what formulation are you going to give?
1 in 1,000.
1 in 1,000 or 1 in 10,000? What's the number?
1 in 1,000.
It's 1 in 1,000. Okay. The idea is you give the more concentrated form if you're doing intramuscular, which is what you're doing. If you were doing it in a cardiac situation, it's going intravenous, you use a more diluted version, which is 1 in 10,000. Okay? So you give your 1 in 10,000 adrenaline. Anything else that you're going to give? So chlorphenamine, yeah? Yeah, steroid. Anything else? So someone said salbutamol. So so if you are listening to their chest and they sound wheezy, or they're sounding as though they've got any asthma type symptoms, you would essentially treat them as you would for an asthmatic. So you would give them the salbutamol and the ipratropium nebulizers. Okay. Anything else? Okay. So we've touched on all of these, which is you do your high flow oxygen, you remove the cause, you give your 0.5 milligrams of 1 in 1,000. You give 10 milligrams of IV chlorphenamine, 200 milligrams of IV hydrocortisone, and if they have respiratory symptoms, then you would give them nebulizers. Okay? So this is something that comes up quite commonly in OSCEs. It can come up as a sort of ABC station, and I was told to inform you guys that apparently it's come up before in a video station, where I don't entirely know what you were asked to do, but there was a video of someone having acute anaphylaxis, and I assume you were asked to explain what you saw clinical findings wise, and also talk through how you would manage the patient. Okay. Does anybody have any questions? Okay. So just before we finish, just to run through a few things that I think are useful for OSCEs. I've already touched on the BTS guidelines. The back of your cheese and onion is great for the acute surgical emergencies. There's a book called Cases for Paces, which I'm sure you'll have in your library. It may sound daunting because it's for cases rather than for finals, but it's really good at going through all of the things that you'll find with most common medical conditions in terms of examination and basic things about how you would manage them. Then there's short medical cases for medical students, which is a similar sort of thing. It's got photos, it's got descriptions of what you can find clinical findings-wise for all of the common things that come up in OSCEs. And then something I found very useful was a book called 250 Clinical Cases in Medicine, which basically, if you can't get into the hospital seeing patients, is your next best thing, because it has scenarios, clinical findings, and then questions with answers at the end. So you can run through with your friends, you can practice doing the examination, and basically they can tell you your findings as you go through, and then they can ask you the questions, get up in your face, pretend to be the scary examiner, practice answering the questions, and you've got a model answer there for you. Any questions about anything at all? No? Okay, alright.